Okay, good morning. Okay, so my presentation is on Lyme and co-infections. In the interest of time, I'll slip through some of the slides because I've presented too many slides here. But basically, ticks carry more than just Lyme. And this is just a slide that shows 30 different bacteria, viruses, co-infections that you can get from a tick. This is a study done in France showing that the ticks are carrying Anaplasma, Bartonella, Borrelia, Ehrlichia, which is a rickettsial infection, and others. This is a study that we did in Ireland where we picked the ticks from 6 different regions of the country, and we have identified between 2 and 15% of the ticks are positive for Borrelia. Interestingly, they're not the traditional Borrelia burgdorferi sensu stricto. They're Borrelia guerinii, Borrelia miyamotoi, and other strains that may not be picked up on the standard antibody test. This is also a study done by the vets, and they went out and they picked ticks around the animals in Ireland, and there are other infections besides Borrelia that the ticks are biting the animals: Anaplasma, which is a rickettsial infection, Babesia, and Borrelia. In Ireland, we can't test for Anaplasma, we can't test for Babesia in humans, but we can test in animals. Going through the diagnostics, as we all know, are imperfect. They don't pick up all the strains of Borrelia. They don't pick up miyamotoi, which is relapsing fever. And in Ireland and most of the world, we're not testing for the co-infections either. We did a study comparing standard antibody tests to some of the newer testing that's done, the ELISpots that are being done in Germany, and the correlation between the Irish test and the ELISpot tests, about 60 to 80% of tests were being missed with the standard Irish Lyme test. So we're missing lots of cases of Lyme, even well-established Lyme cases, not just early cases. This is a study on this slide showing the sensitivity of the standard Lyme testing, ranging from 36 to 70% in one study, 20 to 97%, 34 to 59%. So the testing is not 100%. We need to make a clinical diagnosis of Lyme, and the antibody test, if positive, can be supportive, but a negative test, as you know, does not rule out Lyme. And like I said, we don't even check for the co-infections. So the problem with the Lyme test, as stated, is it doesn't pick up all the strains of Lymes. When you get a tick bite, it's not always Lyme. There's been recent cases in the UK of tick-borne encephalitis, a viral infection. There was a case in Madrid of hemorrhagic fever, Crimea Congo hemorrhagic fever caused by a tick bite. So ticks have lots of different things. And then the challenges of an antibody test is a positive antibody test means you either have the infection or you had it in the past. You can stay, even after treatment, you can stay positive for the antibody test. So you have to look at the patient who's sick and a positive antibody test, and you can have a patient who's sick and have a negative antibody test, and they can have the infection. So that's the challenge. All over the world, there's misrepresentation of the number of cases of Lyme. This is a recent study done in the UK. The UK said there were 2,000 cases in the country, but when they went into the GP practices and did a study, they actually were able to identify almost 8,000 clinical cases of Lyme being diagnosed by the GP. So we tend to discount Lyme disease in America and Canada and Ireland, in the UK. Ireland says there's 20 cases a year. The estimate's actually based on clinical experiences, probably 2,500. So the government is reporting 100 times less cases than actually exist. So the next point really is tick bites frequently go unrecognized. The tick is the size of a sesame seed. If you get it on your nose, you might notice it, but if it's in any other part of your body, you may miss it. The second thing is you may not get a rash. the rash is only found in 25 to 50%, even though in medical textbooks they teach you 80% get a rash. Miyamotoi Borrelia, almost none of the patients get a rash. So we're missing lots of cases. The presentation of Lyme overlaps with many other conditions. Summer flu is classic, and it may occur 3 days quickly or 3 weeks afterwards, but it can be months and months after as well. And the fever, headache, joint pain, and fatigue could be a virus, but a summer virus in a Lyme endemic area, which is worldwide, should be Lyme until proven otherwise. And doctors are not trained to think this. Flu in the winter can also be Lyme, as many of my patients go to Lanzarote, go to southern Spain, go all over the world to tropical climates. So in the winter, ticks are around all year. And with global warming, we have ticks in Ireland in December and January. They don't like December and January. They much prefer April and May, but they still are around and they still can bite you, even in January. Signs and symptoms of Lyme, as you know, all sorts of different symptoms that overlap with other diseases and other conditions. Classic Bell's palsy, often called a viral Bell's palsy. Why not a bacterial Bell's palsy? Arthritis, classic arthritis is migratory arthritis, classically diagnosed as rheumatoid arthritis, atypical rheumatoid arthritis, but may come on weeks to months or later following the infection. So how do you diagnose Lyme? It's based on the history. It's based on multi-system involvement. The rash may not be there. You may miss the tick. And it's a clinical diagnosis. And we have such a low threshold in the middle of the winter for treating people with flu, putting people on antibiotics. I think when we suspect Lyme, we should treat, not look for alternative diagnosis. What happens if you don't treat Lyme? And this is the challenge. We only focus in the textbooks and teaching GPs about early Lyme, but so many patients have what we call untreated persistent Lyme. If you don't treat it, if you miss it, 5% get carditis, 10% get neurological problems, 60% get arthritis, and they may present 6 months, 12 months, or years and years later with a misdiagnosis, and nobody thinks about Lyme. Short-term antibiotics, the studies say short-term antibiotics cure, but there's lots of studies, unfortunately, that are ignored by many of the infectious disease specialty services. Short-term antibiotics fail in 25 to 71% of patients, especially if it's persistent disease that's been going on for 6 to 12 months. If you catch it when it's a rash, probably before it's disseminated, probably a short course antibiotic will do the job, but not all the time. If you're still sick after short-term antibiotics, what do they call it? Post-treatment Lyme disease syndrome. If you have an ear infection and you don't get better after a course of antibiotics, it's called persistent infection, and you get another course of antibiotics. And with Lyme disease, you're told it's post-infectious. The infection's no longer there, but you got better with the antibiotics and it came back again. If it's an ear infection, you get treated again. If you get Lyme, you're told the infection's gone, live with it, which is very difficult to do. So where do the misdiagnoses end up? They end up going to see other specialists, cardiologists, rheumatologists, neurologists. And my experience is that the 25% of tick patients that I saw with chronic fatigue, where I suspected Lyme, they not just had Lyme, but they had another co-infection, anaplasma, which is the same infection that the ticks are being identified in the veterinary studies in Ireland. The challenge is that nobody describes chronic Lyme in the textbook. We just describe the acute Lyme, and that is the challenge. And people argue whether it's ongoing infection or it's post-infectious. Until we have better testing, my assumption is it's ongoing infection. So where do you end up if you're unwell? The UK guidelines say there's no such thing as chronic Lyme, even though there's lots of studies and post-mortem studies showing Lyme being isolated from the tissues of people post-mortem. That's not people dying of chronic fatigue, that's people dying of untreated Lyme disease. So that's the challenge with Lyme. The Infectious Disease Society of America and Ireland follows that, UK follows that, says there's no convincing biological evidence of the existence of Borrelia after short course treatment. And of course there is. There's hundreds of articles that have been ignored. And these are some of the articles in this slide here that show persistent Lyme. The International Lyme Association describes chronic Lyme as a multi-system illness due to ongoing replication of Borrelia burgdorferi. And there's lots of evidence to show that there is ongoing infection. Moving on to congenital Lyme, can a pregnant woman get bitten by a tick? Of course. Do these ticks spread to the placenta and spread to the baby? This is a slide showing yes, indeed it does. And the first fellow who described Borrelia burgdorferi, Willy Burgdorfer, has a case report showing a baby that died of congenital Lyme, and the Lyme was found in the tissues of that baby. This is a case report showing a child born to a mother had a tick bite in pregnancy, and when the biopsy of the child's skin was done, it showed Borrelia. This is the textbook of infectious disease, 2001, showing 263 cases of congenital Lyme, and there's hundreds and hundreds of articles showing that Lyme can spread from mother to child. This is the same book, Remington and Klein, a more recent edition showing over 800 references of congenital Lyme. However, congenital Lyme is not recognized on ICD-11 codes by the WHO. It was given a code this year. However, a very interesting study came out from Canada called a systematic review of the impact of gestational Lyme disease in humans of the fetus and newborns. And they basically said it's questionable whether Lyme can spread from mother to child. They included half a dozen studies, as opposed to the 800 studies from the previous edition from Remington and Klein. And based on this study, I believe, congenital Lyme was removed from the ICD-11 codes. When asked why they were removed from the ICD-11 codes, this is a response from the WHO basically saying there is no evidence of congenital abnormalities with Lyme. Therefore, you don't need a standalone code. However, if you look at congenital malaria, there is no evidence of congenital malformations with malaria, but they have a standalone code. So there's huge inconsistencies. I've been sending communications to the WHO asking for them to reinstate congenital Lyme as an ICD-11 code to Dr. Schwarzlander and Dr. Jacob. And I was told, oh, you can resubmit a dossier to get congenital Lyme reinstated. And my response to that is it was instated and was rejected based on the Canadian study by Waddell et al. Why should we submit a dossier again to have it accepted and then rejected? But there is clear evidence that Lyme can spread from mother to child. So what is the challenge with Lyme? It's not just about the infection. People say it's an immunological condition. People say it's an inflammatory condition. It is. It's an infectious condition that causes immune dysfunction and inflammation, no different than other diseases that I deal with as an infectious disease specialist. Back in the days of HIV, patients used to get immune compromised, they used to get inflammation, and they used to get reactivation of all sorts of bacterial and viral infections. And I think that's the process that many patients with persistent Lyme experience. Transplant medicine, you put people on immune suppression to lower their immune system so they can save their transplanted liver or heart, and then other infections flare up. And I think Lyme and co-infections are no different. So it's complicated. It's a complicated disease. So the challenge is Lyme and co-infection testing is imperfect. We don't understand the complex interactions of infection, inflammation, and autoimmunity. Longer course treatment and multimodality supportive therapy benefits many patients, and we're told we have to follow the guidelines. We don't follow guidelines for ear infections or osteomyelitis. We treat patients based on symptomatic response to treatment. We should be doing the same for Lyme. We need better research. We need more compassion. We need to listen to patients. If patients are sick and you can't figure it out, you don't say the patients are making up their illness. You say we're missing something, and put more resources and science into understanding what's going on. And like I said, Lyme does spread from mother to child, as well as the other co-infection. And the effects of the unborn child and infected child is real, and we need better prospective studies. Thank you.